I'm starting.
Ma'am, please start. Thank you.
Neurodevelopment in children refers to how a child's brain, nervous system, and cognitive ability grow and organize over time, which further enables growth of learning, behavioral, and social skills. Early childhood is a critical period as the brain develops at its fastest pace, shaped by both biological factors and everyday experiences. Role of the first contact pediatrician is pivotal in monitoring this crucial development and detecting any aberration from normal at earliest. Keeping this concept in mind, WPF has come up with this unique idea by forming such a creative webinar on this sensitive topic. Good afternoon, all the vibrant ladies and audience in this beautiful spring afternoon where colors of Holi festival are spread throughout the subcontinent. Flowers are blooming, soft wind is singing, and the butterflies are guiding. With this background, I invite our chairperson, Dr. Madhu Raturi ma'am, for her welcome address. Over to you, Madhu ma'am.
Okay, my warm greetings to all the respected seniors are there and dear colleagues. So I, Dr. Madhu Raturi, welcome you all to this very important and informative session on any neurodevelopmental issues. As we all know that a healthy body can be in a healthy mind, and we have to be very, very attentive and conscious whenever we are giving consultation to any children with these such type of issues. And for me, the word is earliest. It is not even earlier. Earlier, the better we say, but earliest is the best, so that we can help these children to live a normal life. Today's moderator is Dr. Shikha Garg, and all the panelists are doing wonderful job. Dr. Jaya Shivalkar, Dr. Nirali Lohia, and Dr. Anshita Arora. They all are doing a good job for the neurodevelopmental chapter, and they are helping children to live a normal life. I always learn from these torchbearers, the young minds. So I would like the give more time to people who want to have some queries or something. And with this, let's start, Anuradha.
Thank you, ma'am. First of all, I should uh, introduce our panelist and moderator. To moderate today's section, today's part, there is a brilliant moderator, Dr. Shikha Garg, who is developmental and behavioral pediatrician at Baby Loans Newton Institute of Child and Adolescent Development Center at Jaipur. She is national convener in Next Gen Pediatrics, joint national convener in OPSIS IAP Action Plan 2024, master trainer of the Sankalp Sampurna Swasthya Karikram, and poor school performance, or both are part of IAP action plans. She has been state coordinator of the Neurodevelopmental chapter of Pediatrics 2023 and 2022. She is having various publications in her pocket. With this, I invite Dr. Shikha Garg to moderate today's panel discussion. Over to you, Dr. Shikha.
Uh, Thank you so much, ma'am, and a very good afternoon to all present here. At the outset, my thanks to this platform, WPF, Madhu ma'am, Sangeeta ma'am, Anuradha ma'am, and all dear seniors to give me this platform. It is always a learning when you are interacting with such esteemed panelists and esteemed participants over here. Without further await, I shall share my screen and start with the panel. We have a team of very esteemed and learned panelists with us. Is my screen PPT full screen?
No, ma'am. PPT is not full screen, but we can see your PPT.
Yeah, I'll just
Kindly reshare it.
Is it now?
Yes, ma'am. Yeah, thank you.
Yes, yes. So, for our respected panelist, we have Dr. Jaya Shivalkar ma'am. She's Director Child Development and Activity Center from Nagpur. She is Executive Council member of NIE PID Secunderabad, Research Committee member of Maharashtra State Disability Board, member Regional Mental Health Board, Maharashtra State, and ex-chairperson of MAHA IIP Women's Committee. A very warm welcome to you, ma'am. To join her is Dr. Nirali Lohia. She is consultant developmental pediatrician, again from Nagpur. She is trained in various national and international courses, and she is the National Joint Coordinator IIP NDP Fellowship and West Zone Coordinator for this year. She is also part of Technical Working Group UNICEF for District Early Intervention Center. So this is very important. She has various publications and she is reviewer of Journal of Autism and Developmental Disorders at BMC Pediatrics. Not the least, we have esteemed Dr. Anshita Arora. She is pediatric neurologist working at Udaipur, American Institute of Medical Sciences and GBH Hospital. She is a clinical and research associate at the hospital. She has done it from Jaslope, and she's a sub-investigator, international multi-centric randomized control trials and institutional academic studies. She is also a member of LICNA for 24-26, and she has been the same in past also. She's EB member of IIP AOP and Rajasthan chapter, very vibrant and very hardworking. Welcome all three panelists to the forum, and I am sure we are going to have extremely useful discussion. So today's topic of discussion is managed, misread or missed neurodevelopmental conditions in practice. Every visit counts. So let me take you to a journey of a typical child of developmental disabilities to understand why we have taken this topic with us. What happens, most of us would agree upon this journey. Parents notice developmental aberrations at say 7 or 10 months. They have two things to follow. Either they will consult a pediatrician, a general physician, or a PHC doctor. And then what follows is pediatrician usually assess clinically without any developmental tools, because we have a busy OPD and we don't have very easy to go or ready to use developmental tools in our busy OPD. And what follows is either the pediatrician would assure if the child is very mildly delayed or not very extremely affected, he or she will ensure that the child development is inevitable. Just wait and watch. Or if the child seems to be very clearly affected, then he or she, the doctor can say that declare the condition is incurable and no little treatment is required or available. Or best part, the pediatrician would refer the child to the specialist. But now what happens when any of these three paths are taken? If the child is being assured, despite of having early delays, the child problems get neglected, develops secondary complications, and goes into a vicious cycle. So the condition was misread, and the child was assured to stay and to wait. Even if the child's condition is missed and the child goes into the same condition. But what happens when the child is referred to the specialist? The most ideal situation which can happen, most of the times the parents are not able to afford the multiple specialists. There is no time for regular follow-ups as this demanding field asks for. All the specialists are not available at all. There are a handful of people doing developmental pediatrics all over the country. So what happens again? The child's problem gets neglected, develops secondary complications, and again the condition goes into the vicious cycle. So whether the condition is managed, whether the condition is missed or misread, most of the times the condition gets neglected because of the lack of proper services available. Now what happens? There is one more thing which happens a lot in India is they consult a faith healer, and again the child's problem gets neglected. And that is why we have taken this topic, so that we can have easy tools, we can have early detection, and we can help the child at each level. It is not always necessary that a developmental pediatrician is required. And why we say every visit counts is early intervention impacts the life course. Behavioral competence and trajectories increases markedly when we decreases the risk factors and we increases the protective factors. As you can see in the graph, there is marked difference between the childhood development when the protective factors are increased and early intervention is done. So the idea is to increase the developmental surveillance at each visit, at each OPD let it be pediatrician or a PHC or a GP. No child at risk should be missed, misread, or mismanaged. To differentiate habilitation versus rehabilitation, this is a concept which has been floating around now. And to define the role of all stakeholders. Now, the stakeholder is not just the parent, the stakeholders of such children are the doctors, the teachers, the community, and the society as a whole. And we have to define the role of all of us to reduce the burden of neurodevelopmental disorders. Now, what is habilitation versus rehabilitation? Habilitation is a process of prevention of impairment going into disability. So the early we detect, the early we have to start the process of habilitation, the preventive strategies. Whereas when we detect the child late, rehabilitation involves the prevention of disability, and that we can only restore or help the child a little bit. So the message here is clear. What we require are good clinicians to manage children with developmental disabilities, and not a developmental specialist everywhere. So we have to empower all the people out here and in the community to help these children. With this, we will start with our panelist. And my first question goes to Dr. Nirali, where it is said that developmental delays usually resolve on their own as the child grows older. What is your comment on this, Dr. Nirali?
Thank you, Ratishika, for the question. Good afternoon, everyone. Thank you, WPF, the offset, to give me this opportunity to be a part of this wonderful panel. Seriously, a great thank you from my end. It was wonderful. So, as we can see, many of the time casual comments, I'll say rather than it's a myth, it's more of a common practice that we usually in the busy OPD pediatricians say that bacha theek ho jayega, developmental delay is going to take their own course of time, but the child is going to come out of it. Rather than using any screening tool, what you were mentioning, rather than equipping themselves with the available tools, and most importantly, the busy OPD, less time. Usually what we see, 20 patients are waiting, I have to finish the patient in 5 minutes and I have to complete my common consult as well. Next slide. So what they usually do, they give some passive comments. They just observe the child. They'll write some one or another multivitamins or the brain supplements. And this is where the problem arises. As Madhu ma'am, next slide. As Madhu ma'am was mentioning, earliest is the best. Even not early intervention is matter. Because every milestone is a ticking bomb. Once the red flag has been reached, you have to use any screening tool to make sure the child is falling into delay or not delay, rather than just saying, I can see from my angle or my experience, the child is not falling into delay. Because we are losing the critical window. As we all are aware that 70% of the brain develops by the age of 2 years. It doesn't mean that the child will not be able to learn new skills. However, that proportionate growth will be always around 70 to 75% only. So even the ancestors of our used to say, a stitch in time saves 9. So for it, every day matters. For a child of a 10-day-old or 15-day-old, make sure every day matters and we have to act as early as possible. We have to be proactive.
So message is clear. We don't have to wait and watch, take the wait and watch policy. Let us discuss our first case where this 10-month-old Ekan sitting with support. He rolls over both the ways, but he is not sitting independently. All the growth parameters are normal. So what happens is this child visits the pediatrician. The mother says he's not sitting, and he's usually given some calcium and advised to wait a little. I would like to ask Dr. Anshita, is this variation or delay? Should we be waiting for a little more time? At 10 months, the child is not sitting without support. And what motor milestones should we worry, or what are the red flag signs in such children?
Thank you,
Dr.
Dr.
Anshita. Yes.
Yeah, thank you, Dr. Shikha. And heartfelt gratitude to WPF for this beautiful opportunity. So, yeah, सबसे बड़ा जो हमारा issue रहता है, what we think is that a 10-month-old child coming with a complaint of not sitting independently, अभी ज़्यादा late नहीं हुआ है, wait and watch करते हैं. So, how should we proceed in that case? Next slide, please. Yeah, so first we need to look that उस age पे, particular age of 10 months, what is the expected development should be happening to that child. A 10-month age, definitely the child should be sitting independently. If the child is not sitting, we need a careful observation along with a detailed history as well as a basic but a good neurological as well as physical examination. Because by that, what we'll be doing? We'll be picking the red flags which get missed usually if we just say that, okay, 1-2 महीने ही तो delay है, हो जाएगा proper. Because in that case, we will definitely go for a screening tool. Second, we will prevent ourselves from doing a over or under diagnosis. Maybe we are over-diagnosing the child that, oh, 1 month delay ho gaya, that means it is a development delay. And maybe we are under-diagnosing because we have not taken a detailed history, clinical examination was not done. And therefore, we need the child to be managed holistically along with the development history, clinical history, as well as examination. So coming to the case, like this is a 10 months old child, not sitting independently. What should be the first thing? So first thing should be checking development milestones along with the trajectory. The trajectory word is more important in my context because the development delay could be just a variation or maybe a mild delay or a severe delay, but we want to know that 10 months ka bachcha hai, neck holding kab achieve hua, rollover kab achieve hua, when he started sitting with the support. That you mean by the development trajectory. And also, if there is any history of regression, that is very important. First, the step would be checking for the development milestones and trajectory. That would be the first arm. Along with the second arm would be a history that should include a very brief, and it will just take a 1 minute to complete as the history. Prematurity, neonatal complications, and just the cultural practices in the environment which is happening. Because there are few of the communities or few of the parents like not giving a stimulation to the child, no sensory stimulation, no physical activity. In that case also there could be a mild delay. And along with there should be a neurological and a general examination which should be quick, very fast and very basic, which should include definitely your tone, power, reflexes and asymmetry. So that's 4 things which should be included. In the general examination, dysmorphism and neurocutaneous markers, that should be there. And also, if the complaint is motor delay, it's not necessary that it is only a motor delay. It's important to understand that the child is delaying only in one domain or there is a delay in 2 or more domains. So if we get a normal development trajectory, like the neck holding was at 3 to 4 months, rollovers was okay, sitting with support was okay, and with a normal history and examination, then maybe we are dealing with a variation of mild delay, but that case also, we need to start on early intervention and stimulation and reassess in a month time. But if the trajectory is abnormal, like he started neck holding at 7 months and rollover just now, that makes the child delay from the very beginning, and that cannot be a variation. With abnormal history and examination, the child needs evaluation. So at any age, the red flag should be considered as delay in development trajectory, any history of regression that the child was doing and now he has stopped doing that thing. Any of the tone abnormalities, the asymmetry of movements, like 10 months where there is a hand preference in the child is there, or in the weight bearing, the child is not bearing weight on the one limb, and there is a history of global development delay, the child should be done evaluation further with the screening as well as with the diagnostic test.
Thank you, Dr. Anshita. So clearly, Dr. Anshita has mentioned 2 trajectories. One is clearly a neurological signs are there. We have the things, and we will move on to MRIs and sending the child to physiotherapy and all. But what if the child falls into the second category, variation or mild delay? And here, Dr. Jaya, my next question is to you. Now, even if the child is mild delay with no neurological abnormalities, should we advise any therapy at this stage? And second question, if the therapists are not available, as is the case many a times, can parents be guided to something to be done at home at this stage? Jaya ma'am.
Good afternoon, everybody, and thank you for having me here on this prestigious platform and a very interesting topic with an interesting title. And the most important message from title is that every visit counts, and that pediatrician needs to understand. And I would definitely request all pediatricians here, because frequently what we are saying, busy OPD, so we are not assessing. So just a gentle reminder that yes, OPDs are busy, but these developmental issues can be managed on Saturday afternoon, or maybe sometime you can give in a week, so that you can call the patient back again. So need not disturb your routine OPD, but at the same time we have to respect the parental concerns, as well as a pediatrician needs to understand his role, because all through the journey of developmental delays, pediatrician is extremely important. So empowering ourselves as a pediatrician, and many times removing that barrier that development is not my forte, and child needs to be sent only for therapy. So we have to remove that barrier from our mind. Yes, we can do a lot. So stimulation and therapy needs to be started immediately. In fact, if we have a very list of high risk neonates or some high risk concerns. So there we don't even wait for child to manifest delays. So that time a pediatrician has handled in NICU or during vaccination, he should be able to pick up at earliest and start with the stimulation and therapy. So that is very important that we have to start. Secondly, what to tell parents? That is very important for a pediatrician to understand that I don't know how to give therapy or I cannot tell the parent or guide the parent. So just simple instruction to the parents that you keep on engaging with the child. So child may have motor delay, may have associated other delays. So keep engaging the child, keep talking to the child, give reactions to the child's actions, keep your surrounding lively, interactive, and learn to anticipate. What is that? Because we know normal milestones. So when the child is rolling, parents should anticipate what is going to happen next. So that pediatrician can definitely tell the parent, "Ki, this is the next milestone. We have to anticipate and let child's movement be all in that direction." So even if we give this simple advice, the parent become alert. They start interacting with the child. So, as we are giving some medical treatment or therapy, the environment of the family house is very important, and we must emphasize on parental engagement. Then we go next step is we have to train the parents. So every time developmental therapies may not be available, may not be approachable, not many trained therapists are available. So what we tell them is a home-based therapy program. We can have online consultation with experts, and parent can get trained because something is definitely better than nothing. Okay, and pediatricians need to monitor, and nowadays parents are quite conscious. They can afford, and definitely they can have some even visit to another city if that is not available. But you have to emphasize, pediatrician needs to emphasize. Another thing is now we have at many places DIEC, that is District Early Intervention Center. So the pediatrician should be aware of this early intervention center which are available at district hospital, and parent can definitely visit there and take the advantage of them. Along with that, we have to tell the parents about the emotional connect with the child, give eye contact, give response, focus on total communication, focus on emotional expressions, so that even if the child is lagging in one domain, the other domain will definitely catch up, and that will help the overall development. So pediatricians are important figure. Busy OPD cannot be the excuse because this is not emergency. You can definitely call them one day, 2 day after, and give at least some time. Pediatricians know normal developmental patterns so that you can tell them the positions and all those things. And definitely you can focus on overall engagement of the parents. So yes, pediatricians are important, and we can start with home-based intervention.
Thank you, Jaya ma'am. Ma'am has raised at very significant points. One, we don't have to wait and watch at any point. Red flag means red flag. If we have the cutoff milestone not showing up, we have to act and do not wait and watch. Second, ma'am has in short very nicely told about the 5 pillars of nurturing care of ECD program. We have to tell them, and the anticipatory guidances must, as ma'am has mentioned. A little mention about calcium supplement. So it is not a milestone medicine, I would say. It is indicated only when the vitamin D or calcium is less. So assess clinical and biochemical signs before child is not walking, child is not sitting, prescribe some calcium. That should not be the practice, and we should be avoiding blind supplementations. Role of early therapy in motor delays is there. We have some early intervention modules from neurodevelopmental chapter which can be learned and taught to the parents. It improves definitely the long-term outcomes and prevents the compensatory patterns. As we all know, neuroplasticity is highest in first year. Parental training and early stimulation is extremely important because that is how, as JMM has said, even we don't have therapists, we can have online consultations. We can ask them daily repetition at home. We should ask them to avoid walkers and support sitting place in this case, and the next milestone which is expected in all other cases. Moving on to our next myth and fact, Dr. Anshita. Now, this is another thing which we keeps on listing in our OPDs a lot. So, young couples who are coming from AI generation and all the screen tech savvy people, screen improves learning. So, whenever we say then do not give them the screens, speech delay ho jayega. They're learning so much from the screen. And also, the second myth around speech delay is since father or brother or mama spoke late, no, nothing is to be worried if the child is not speaking. So just a little insight upon how do we deal with these parents and what is the actual fact around these things.
Thank you, Dr. Shikha. So this is a question we all, as a pediatrician, development pediatrician, and as well as neurologists, get stuck in the OPD as well as IPD. That what parents think and what science says. So what the parents say, they say that screen time provides them better learning. मैम कुछ नहीं बोल रहा था, स्क्रीन देखने के बाद एटलीस्ट राइम्स तो बोलने लगा है. He can say at least A for apple है. So that is the thing कि मैम हम टाइम नहीं दे पा रहे, but screen उसको कुछ सिखा रहा है. That is the thing. But the child can say a rhyme, the child can say A for apple, but the child cannot say that, oh, I want to go for a susu or potty, or I want this. So external and internal needs the child is not able to indicate. So that's the thing, that screen is providing them a learned, interverbal learned communication, but what is not learned, what should be the social and language skill for the age, they are lagging that thing. Second thing is that digital exposure boosts the intelligence. In the initial years, for 2 years, 3 years, they find that, wow, beautiful, that the child has become so intelligent by screen. He knows everything. But when he is in school at 4 years and 5 years, the parents start getting complaints from the school. He is having an attention, behavioral issues, hyperactivity, and suddenly the light gets on. Oh, what happened to our child? And the last, but it's a very factful thing, that the real world is more informative than the real world. That is completely a myth, because actual learning still today, हमारे पास आज इतना AI tool है and everything is there, then also the actual learning is a play-based two-way interaction. If we talk about the very young kids as well as for the adults and adolescents, for everyone it is a two-way interaction, which is actual learning. So we need to understand and to make the parents understand, next please, that screens are the tool and not the caregivers for the child. And coming to the second part of the myth, just a single line, because we'll be dealing further for that if the father is having a delayed speech or the uncle is having a delayed speech, that's why he is speaking late. I always tell two things to the parents in that condition, that only speech delay doesn't make the scenario complete. We have to have a complete scenario that the speech delay is associated with social and communication delay also. One thing. Second thing is that, okay, if you think that the father spoke late and that's why my child is speaking late, you can wait till 5 years, but you cannot make the child again of 2 years or 3 years to start the intervention if he doesn't start speaking at 5 years. So that is important, which we need to tell the parents. Thank you.
Thank you, Dr. Anshita. And we also have IAP and AP guidelines about screen time, which I feel we should all be displaying in our OPD, big posters regarding that, so that parents can read while they're waiting outside and know. Sometimes parents would not ask, but they would be dealing with such situations. Moving on to our second case. So this is a 2-year-old boy not talking, Hanu. He has 8 to 10 meaningful words, speaks something, 3 to 4 hours of daily screen exposure. Family is very relaxed, I would say, because parents say that he knows everything. He's rhyming, he's saying some ABCD, and family history of late speech is there. Mama spoke late. So, and you have got this child in your OPD when the child has come for, say, vaccination or some ARI issues. Now, my next question goes to Dr. Nirali. 2 years and 8 to 10 words. Is it normal variation? Should we be waiting, or should we get this child on some workup? And what are the red flag signs we should look for this in this child?
So common case what we see in our OPD. A 2-year-old speaking only 8 to 10 meaningful words. Okay. So slide. So if we can see the red flag signs, okay. 2 years of age, at least we want 50 meaningful words. In fact, many experts say it's almost 200 to 300 meaningful words and 2-word phrases we want in the vocabulary. Usually we ask about language and speech and everything. However, we forget other milestones. So first of all, to know about variation and delay, I'll ask about the detailed history, whether the motor milestones are going good, whether the socio-emotional milestones are going good. What about that? Because parents are saying he knows everything. So that what is everything for them, we have to inquire. Because as you are saying, tech-savvy world, many parents are coming with the Google and so many things. They miss sometimes the important observations what we see in our OPD. So it's more important. Fine motor and socio-emotional milestone, next slide, should never be asked. It should be always observed. You ask one of your receptionist staff and see whether the child is looking at that new person, whether he's acknowledging that person, or whether he's just engrossed in the toys. Whether after looking at the new person, the stranger, whether again the child is moving to the caregiver, seeing the child for comfort, who is he or who is she, that is more important. So socio-emotional milestones at 2 years are more important than the direct speech or language milestone alone. A pediatrician can simply do a simple ASQ or MChat. Next slides. If you can use simple ASQ or MChat in your daily routine practice, it will count all your visit, like every visit counts. Okay. Make sure you just don't say, I have gut feeling, I have experience, your child is going to speak because the father is a late talker. That's already everybody has emphasized. There is nothing like father is a late talker, so is the child, so is the male child, or anything. You have to observe all the milestones. You have to make sure, inquire about all the patterns, who is the caregiver, how much they are interacting with the child, is the only the screen, is the babysitter or what. So you have to make sure, next slide, that you don't have to say, child looks to me delay, go to a speech therapist. You cannot bypass a pediatrician or a developmental pediatrician and directly refer to a therapist, because therapist center model will only focus on speech and language. What about other milestones? Sometimes you are not able to engage enough in more constructive manner, and so the child is having language delay. That intent of communication is more important rather than just asking about the delayed language. And what you are expecting from a developmental pediatrician, you cannot just expect a screening tool to be done, or an observation questionnaire, something to be done by a developmental pediatrician. A developmental pediatrician has to run a DQ test. When you are knowing red flag is achieved, child is already delayed, do a DQ test. This language delay may go into ADHD, may go into ASD, may go into even learning disability. You should have some baseline for this child. You have to assess exact developmental age equivalent in months. If the child is falling less than 70%, it qualifies for a delay. If it is more and going towards on the lower side, it is more and delay, severe delay, profound delay. If it is about 70 to 85, slow, just stimulation at home is required. You can say your parents, घर पे हो जाएगा पर आप काम करो. We have to keep a watch and a follow-up is required. More than 85, your child is good to go. So make sure before DQ evaluation and give the final test results, don't dismiss the child or don't directly refer to a speech therapist.
Thank you, Dr. Nali. Very well emphasized upon two things. When the parents say the child knows everything, we must keep in mind that speech delay is not equivalent to cognitive delay. बच्चा अपने चीजों को लेकर आ रहा है, खुद पानी पी रहा है, खुद ऊपर चढ़ के सारे टॉयज ले रहा है. That doesn't mean that child will not have any medical condition pertaining to speech and communication delay. So a complete and thorough examination regarding all milestones is very important. And receptive speech is equally important, as Dr. Nirali mentioned, that we have to see whether the child is acknowledging the parent. So even a small gesture to a 2-year-old, asking him to take some toy, looking if they are not looking at the parents or not, or what social emotional behavior they are showing is really important. Now again, after we have dealt with this child, and suppose the pediatrician has done MChat and that has come out to be 8, or the child is into high risk category of ASD. Now, my next question goes to Jaya ma'am. So, ma'am, we see that a child is not speaking and a child has some other difficulties also. Should this child be sent to a speech therapist directly? Some of it has been answered by Dr. Nirali, but ma'am, we would like to take your expert opinion over this.
Yes, very important. Because as a pediatrician, developmental pediatrics, developmental delay, any delay, refer to therapist. We need to break this norm. It is very easy to refer, but definitely that is not going to help the child. Maybe the child will not even come back to you. So the first thing I would say that we must check the hearing. Any speech delay, you have to check the hearing. So that is the first message. Secondly, general pediatricians are afraid of assessments. So whenever there is a word comes कि इसको assess करना है, so there is a little barrier. So instead of assessment, technical assessment or screening tools, as a pediatrician, you have seen so many children. So if you observe, you know that something is lacking. And if that something is lagging, your first reaction should be give a separate appointment. Spend 10-15 minutes with the parents and child. That will give you much information. Secondly, speech therapists in India, they are rare commodity. So first of all, you must see whoever is claiming to be speech therapist is actually speech therapist or not. Secondly, only speech is not required for child with autism. Many times child will not even present with speech delay. Sometimes children are talking too much, which might be in the form of echolalia or irrelevant or repetitive speech. So you need a complete assessment and program for speech as well as language as well as communication. And not many speech therapists are trained in that. So your coordination with speech therapist is very important. Whenever you are referring, it's a responsible thing, and follow-up is essential. Along with speech and language training, we need social training. So now the concept of therapy to autism is gradually changing from room-based therapy to social therapy. So that also needs to be included. Another thing is we need to have a comprehensive management. Like we are not only focusing on speech, we are focusing on interaction, we are focusing on eye contact, we are focusing on fine motor skills, we are focusing on responsiveness, interaction. So all these things become a part of comprehensive management. Sometimes you might need medication if the child has hyperactivity or any other associated issue. OT and PT, again, I would request all pediatricians to be very careful, because again, we are in a uh, uh, changing format where we don't recommend OT for each and every child with autism, because it has plus point as well as it has some negative points. And all expert OTs may not be available. Even in Nagpur, we don't have good OTs which would be giving exactly SIT or sensory integration therapy. So a blanket reference to speech or OT is not recommended. Pediatricians can do a lot by, just empowering parents to integrate child in his family, his social environment, neighbors, and school, which is very important. So parents are very important part of this management. And along with this, for if you're talking about autism, behavior management is very important. Next. And just I would take few minutes to tell you that, the way child speaks, what the child is speaking, how the child is speaking, the content of speech. So much information child is giving about his development. And just from speech language communication, you can predict so many things in child development. So it could be speech problem, it could be communication problem, it could be language problem, which can lead to even learning disabilities. So delay in speech needs to be assessed. It could be deviant speech, there could be stuttering, there could be dysarthria or other speech disorder, there could be problems related to the phonation, articulation, fluency, even the voice is also one of the important, like we have some children with very different voice that affects their personality. It can be part of only speech delay or it can be part of global delay. So speech is very important, and every pediatrician can easily assess the speech if you spend little time with the child and parent. So very important, and thanks for considering this.
Yeah. Thank you, Jia ma'am. So the bottom line is goal-directed therapies has to be the norm. It isn't that child is autism directly sent to OT or speech. We have to set the goals and we have to see where the child is at the developmental age, and then we have to identify the goals rather than blanketly sending them to XYZ therapist. Also, not all speech therapists takes therapies for autism kids. So that also we have to keep in mind when we are directly referring the children. So family history doesn't negate the red flag signs. If it is there, we have to consider the assessments. Shy child warms up gradually. Social delay is very important when we are dealing with expressive speech delay. Uh, Now, when to start refer and start therapy, as Dr. Nrali has already mentioned the high risk factors, I would not go into this. We will directly go to the third case where Mukesh, now a little older child with 5.5 year old, he cannot sit in class. Very common complaint comes from the teachers that he is impulsive, interrupting. impairment across the settings, and parents fear medications. So many a times what happens is complaints from the school, the child is labeled ADHD, went to some specialist, asked for some medications. There is so much taboo around the medications that the same scenario keeps on continuing, and many a times child keeps on skipping one school after another. Now, my first question about this hyperactive child is to Dr. Nirali. What medical conditions should this child be directly labeled as ADHD, or we should be looking into some other medical conditions also which can give such picture rather than just neurodevelopmental conditions?
Again, thank you, Shikha, for the question. I usually say developmental pediatrics is a very cumbersome field. After 5 to 6 patients of OPD, usually we start feel foggy. So a comprehensive history and a detailed evaluation, that is what is required for each and every case. It takes almost 45 minutes for one case to be completed. We cannot just say more of a screen exposure, take the school feedback, do some evaluation investigations and come back and the case is rest apart. No, it's not possible. We have to root out neurological conditions, we have to root out psychosocial conditions, and most important, the medical conditions, what you are saying. Many of the times, even the parents are like, the child will not cooperate, his fear of vaccination has not gone well with all the clinics. So we have to ask for the home videos of with the child as well. As I always say, observation during the history taking is very, very important. Whether he's too restless, whether he is seeing the authority figure, he's trying to make refrain himself, again he's trying to climb over himself or here and there because he's not able to control or emotionally regulate himself or what. So important will be first the observation during the history taking. Most importantly, feeding and sleep patterns also need to be asked, not the present habits, even the early infancy. Because the sleep disorders are very prevalent in neurodevelopmental disorders, almost as high as 80%. So always ask about the sleep habits as well in early infancy. Now moving to the medical conditions, as you are saying, vision and hearing, they are the two forbidden twins, I'll say. If they are impaired, they may lead to restlessness and a lot of conditions, virtual ASD, virtual ADHD, what we talk about. However, they can be comorbidly present in all other impairments as well. So the causal association is also there, and most importantly, the comorbidity is also there. So you should never forget the visual screening and hearing screening when you are suspecting any restless or behavioral issues. Anemia, very commonly, even I want to mention the thyroid. So CBC, FT4 and TSH should be written in each and every file when any developmental or behavioral issues is coming to you. As a pediatrician, they can easily scrutinize those things. Sleep, as I was mentioning, you have to make sure they have to maintain a diary, 2 weeks diary to come up with the sleep plans, because again, the sleep, 8 hours sleep will not be there. Child will be inattentive, child will be restless, child will be aggressive, child will not be able to sleep awake early in the morning, and the school will be again having a lot of complaints. As I can see from the history, what you have mentioned, the behavior is pervasive. So even the school is giving one or another complaint. So most importantly will be, you have to collect the psychosocial condition histories as well. For example, if there is a neglect in the family itself, or from the school itself, or the part of bullying is there, or whether the parents have not given equal social opportunities. He doesn't know how to create a boundary or how to form a boundary, how to have an appropriate social interaction with others. So even the psychosocial conditions in our field should be clubbed into the medical conditions only. We need to scrutinize all this before labeling any child with ASD or ADHD, because stigma is attached with all the neurodevelopmental disorders. It's going to be chronic. But these conditions are very much treatable and they are very increasingly prevalent in all patients. So you have to scrutinize.
Yeah, thank you, Dr. Nirali. A little word about sleep issues. So we also see a lot of adenoid hypertrophy, snoring, and those kind of things can be managed by at the pediatric OPD as well before sending the child for ADHD evaluation. So it's not only about 8 to 10 hours of sleep; it is also about the quality of sleep which matters. Now, suppose this child has been diagnosed as ADHD, and then what now? Parents are fearing medications. So, Dr. Anshita, what is your clinical experience regarding therapy versus medication? Should this 5.5-year-old put on medications? And the most common myth is medications are addictive. So, even if the child is functionally not doing well, parents are very scared of giving medications to these children.
Thank you, Dr. Shikha. So, therapies versus medicine. There is no single approach to that. We cannot say that we want only therapy or medication should be given. It should be customized approach depending on the child as well as the level of severity he is having and the functional impairment he is having. So symptoms, how much they are severe, how much functionally they are impairing the child in the activities of daily living. And also, it is important to note that the symptoms are occurring only at one place, one setting, or more than one setting also. So this is a very important thing, because if it is happening only in one setting, it's situational. It's not a behavior. It's happening in all settings, then definitely there could be a part of functional impairment in that. So first part should be a assessment of its severity and how much functionally the child is getting affected. So there are milder symptoms, not very much. Sometimes like parents come कि बहुत मस्ती करता है, but school में बिल्कुल अच्छा रहता है. Then I always ask them to get a school video. And when I see in the school video, he is same as at home. The parents are not realizing कि school में भी same ही circumstances हो रहे हैं. Only thing is that the teachers are not saying that this is happening in the school. So in the milder symptoms, very young age child and only fewer academic concerns. We should definitely first go for only behavior modification, parent training and school-based intervention. And after 2 to 3 months of starting everything, rechecking that it has been done or not, because explaining them the modification or explaining them the training doesn't mean that it has been followed for 2 to 3 months. You have to check that it is done or not. And if they are doing it in a proper way, the things are going in a proper way, and then also there is a poor response, and the child is above the age of a guideline that we can prescribe the medication, then we should go for that if required, not in all the cases. But if the child, if the child is having mild to moderate, moderate to severe symptoms, the child is very impulsive, very aggressive, hitting himself, hitting everyone in the class or the teacher. He's having a lot of risk-taking behaviors in the class. Significant academic concerns and school complaints are there. In that condition, we may need to consider medications along with the therapy after ruling out the rest of the things. So basically, as Dr. Nirali has truly mentioned, that ADHD may overlap with other medical conditions also. It's not like that ADHD ko overlap nahi ho sakta. Like sleep problems could be a part, vision and hearing could be a part. So ruling out the conditions, seeing the school behavior, seeing the psychosocial environment, if we think, then we may to start. I always prefer a combined approach, doing a evaluation, taking a proper school and a home history, because that gives a better outcome, because the therapy may help in the skill development of the child, but for the skill we need a self-regulation, and for that regulation we may sometimes need the therapy. And coming to the second part of the question, that ADHD medicines are addictive, this is completely a myth. ADHD are not medications are not addictive if used in controlled and therapeutic doses, but important red flags or important points to remember are, please next, that should be started after establishing the correct diagnosis. I get a lot of kids with learning disability, autism, ID labeled as ADHD and started on medications without any intervention. So should be started after getting a correct diagnosis, with regular monitoring and dose titration should be done, and it should be combined with a good and appropriate therapy, because there are two sets of parents. One say we need only therapy, no medications, and another set say please ma'am kuch medicine de dijiye, we cannot go for the therapy. We need to explain them that the medication should be combined with the proper therapies for the skill development and ADL development of the child. In fact, well-managed kids have lesser chances of addiction or the substance abuse in the future life. The medications are not addictive. Thank you.
Thank you, Dr. Anshita. And the baseline take-home message here is, even after we have done all the assessments, good diagnosis and putting the child onto therapies and medications, the main role here comes for us as pediatricians is hand-holding the family. Even if we teach them all the home-based managements at school, behavior modifications, doing it is a tough task, and we have to constantly motivate the mother. The mother is the person who will be doing it. Father doesn't take the responsibility, and it is difficult for a mother to take care of a hyperactive child. So constant hand-holding, constant counseling is because they will be coming to us pediatricians for small things, right? They will not be going to developmental pediatrician for every URI or LRI. So constant hand-holding, motivation, and telling them and following the milestones has to be done at the pediatric OPD only. Now, Jaya ma'am, what is the role of parenting with school, partnering with school and parents in these children? We cannot send every child to the therapist, right?
Yeah.
So how does society help?
Yeah. See, very important word you have used is hand holding by the pediatrician. And let me tell you, the parents of hyperactive child leave this hand frequently. hyperactivity is one of the important problem where there is a lot of dropout. Why? Because otherwise the child is doing well. Nowadays, next slide, please. Nowadays, even schools are not even complaining much about the academic issues or behavioral issues. They have a counselor, and they are afraid कि कितने सारे complaint करने हैं. Our counselor would manage it. Let the child relax. बच्चे हैं करते हैं, and the parents are not aware of the child's behavior in the school, and that is why this parent, student, teacher, doctor all need to be in a collaborative mode for better management or correct management of child with ADHD, because ADHD doesn't go away. Maybe the hyperactive motor part might be controlled as the child is growing, but the mental hyperactivity, impulsivity, and maybe the aggression, that doesn't go away. And we have lot many teenagers, young adults who are having problems, maybe in the behavior, maybe they will turn out to be juvenile delinquent or academic dropouts, or this cyber crime, and so many things can be an outcome of this hyperactivity, and parents are not aware of this. So definitely medication, as we have discussed, uh, with the parental counseling, as and when required, we need to that. Behavior modification is the core treatment. And again, as we all are aware, everybody is not able to do that, but definitely pediatrician can keep a track of it and keep guiding in between whatever visits they are making. Maybe reassuring parents, maybe motivating parents, maybe forcing parents sometimes that you have to address these things. So combination of these two things are important. Whenever we don't have proper behavior modification person in there, you can definitely use sports as a therapy. So parents can have a talk with the sports teacher, and you can use sports as a therapy for these children, which is very effective in controlling their hyperactivity. Some sort of discipline is also coming up. If they are not doing well academically, their achievement in sports can be a very good booster for them. So sports is very important. Counseling of child and family again is very important. It has to be done. There is no other option for it. Then classroom management and exam support in consultation with the teacher and the school management has to be provided, because little bit of good marks, good performance, they are very booster for a child, and they it really helps them to control their behavior. So they are very important. Psychosocial support all through the childhood as well as adolescence till young adulthood will definitely help the child to manage himself. Otherwise, many of them would land up with the mild to moderate psychiatric issues. And as we have already seen, diet has a role to play, sleep has a definitely role to play, and screen management becomes very core for these hyperactive children. Hyperactivity can be result of screen overexposure and vice versa. So nowadays, we don't have that. Many times, child will not have that typical ADHD picture, but only hyperactivity or lack of attention because of screen overuse. So all these things are important, and pediatrician need to keep parents. The way you said, hand holding, very important. As and when they meet parent, they have to emphasize all these things. Then only these hyperactive children can be managed in their adolescence and young adulthood.
Thank you, ma'am. Such a well covered topic about each and every point is important, as Jaya ma'am has said, that it is not only about medications and therapies. Remember, not all hyperactivity is disorder, as ma'am has mentioned. It doesn't, not all the hyperactive will come into the ADHD diagnosis, but they have to be managed. The childhood behavior many of times depends upon what are the parental perceptions. So say we have a very well dominated and well disciplined family, they will consider this thing as a little hyperactivity as very great hyperactivity. Or there may be cultural differences or parenting stress which can lead to such kind of picture in the child. But we have to assess and correctly diagnose the child. If the normal childhood energy, if they are in short bursts, there is mild disruption, then a little behavior management and a little parenting guidelines can improve the child. But if it is persisting in more than 2 settings, it is persistent beyond 6 months, then we have to intervene definitely. As Jaman has already mentioned, sometimes this hyperactivity will not be very evident till adulthood. But as you can see, the trajectory of ADHD, if you are not early identifying it, then the behavior disturbances will lead on to some, social conditions later on, like ODD, conduct disorders, legal issues, smoking, which is not considered as a disease per se, but it affects the child, the adolescent life, and as an adult. Accommodating into the social environment may be difficult. Relationship problems can be there, legal issues, addictions can be there. So a little about therapy. Goal-directed structured intervention is required for all the cases and all the children which we discuss. It is not only about sending directly to the therapist. We have to individualize the plans and it requires periodic review. Hand-holding by the pediatrician is very important. 1 hour at center is not enough, and parental training at multiplies the impact, and it is the baseline we all are focusing on nowadays, to train the parents regarding the therapies, the behavioral modification, so that the impact is greatest. Therapy is an ecosystem. It cannot be done in a single CDC. Final integrated message: do not normalize red flags. If it is red flag, we have to intervene. We cannot wait and watch. Early referral is preventive pediatrics, and that has to be done at pediatric OPD. That cannot be done in developmental pediatric OPD. Therapy plus parental training is the foundation. Medications, when indicated, we don't have to. Sometimes even we as pediatricians are very critical about the medications, but we have to use them when indicated and in right doses and right after right diagnosis. They're really very helpful for the children. And time is brain, because if we delay today, that becomes impairment tomorrow for the child. So we don't have to delay. Thank you. So house is open for the questions now. We have a group of esteemed panelists here. So any questions regarding these cases or any other topic regarding to early visits and all are welcomed from the participants.
Dr. Shika?
Yes, Alok sir.
Yes.
Sir, you have to unmute yourself, sir.
Just
Yes.
a small question that the most of the schools are using screen for teaching these days for all age groups. So do we count that screen time in the recommended screen time, daily screen time, or we exclude that time? What should we?
I think Jaya ma'am would like to take this answer question.
There is a little gray zone about this, because not only schools are using screen in the school, but they are giving work on the screen also.
Yes.
So they are sending PDFs, they are sending their homeworks on the this online platform only. So definitely we would consider this as a screen time and include it as a screen time. But if it is too much, then child also needs some extra time, like half an hour on his own. For in such cases, what we would recommend that apart from that, child can have only TV as a screen, not mobile as a screen. That makes a lot of difference. So in addition to their school time, maybe 30 minutes of TV time is okay, not mobile time.
So, Alok Gupta sir, as your question is very correct, it should be included in maximum 1 hour of screen in the school as well. So it is included in normal duration of school, what we see at family. Most importantly, maximum 30 minutes twice a week in school is okay. and then they have to replace it with the traditional methods of chalkboard and everything. In fact, there are IAP screen guidelines for schools as well. IAP has released the guidelines for schools as well. In fact, we are bringing this to the ministry, NDP chapter. Presently, I'm an office bearer. We are working on this, that we have to make sure that child ministry is separate and we have to go screen free or digital free in schools. This is our first motto because it goes unchecked. It literally goes unchecked. हम 30 मिनट बोल रहे हैं, घंटा ही हो रहा है.
In fact, schools are promoting their school ki now we have digital this thing, which is very wrong.
Yeah.
Digital exposure since nursery.
And it isn't about only the screen time presented at school. Now, even the parents are forced to give the screens to the children because they have been given work on screen, and then it converts into playtime on the screen along with it. So we have to really check upon it, and we cannot allow screen time in school to go beyond the recommended things.
Perfect. Perfect. Thank you, ma'am.
Thank you, sir. Preeti ma'am.
Yes, Shikha, excellent. I congratulate all the panelists. I think I'll just share that I share a book called Your Defined Child with Parents. And if you'll permit me, I can put the link of that book. It is by Dr. R.A. Barclay. And it's excellent to give, counseling for parents how to deal with behavior issues. And just a word about the screen time. I think this is where IAP and we pediatricians have a role to play for advocacy. Wherever we can connect with our schools, I think it is very important that we go and talk to the school management. I think if one of us does to every school, it's going to make a whole lot of difference because there are 50,000 of us.
Yes, definitely true, ma'am. We would love to have the link as well. And we all have to advocate these things to the schools of our children, probably, where we can have a say, and we have to gain the momentum over here where we can stop these practices from gaining momentum.
I agree with you, Preeti ma'am. So I did same with my daughter's school actually. They were giving this free time in the school, and I went and I talked to them that this is not to be done actually. And they very warmly accepted that thing that we will definitely work on that. So it's our responsibility as a pediatrician to talk to the schools, not every school, but the school we come in touch with. Yeah.
Yeah.
Excellent, Anshita. Excellent.
Alpana ma'am, you.
Yes, a very good session and very extremely nice session, ma'am, which would really help us in our daily OPDs. I just have a few queries. Like one is like everyone was discussing about school homeworks on.
Dr. Yogesh is also there. Just a minute.
So I just
Dr.
take.
Alpana. I think Dr. Yogesh is also there. And Dr. Asha. Anybody else is there?
Dr. Achla Arya, ma'am,
anybody would
very
like to
senior
say anything?
pediatrician.
I am somewhere outside and there is a lot of noise. I apologize for that. But they can also, I don't know who else is there. Any senior is there? Just
Yogesh,
check.
sir, would you like to comment something?
Yeah, the topics covered are very important and it is very useful for our day-to-day life. And definitely we should talk to the school personals, make them aware about the screen time. It is really very, they do just to reduce their workload.
Yes, sir.
Yes.
Dr. Achla Arya, ma'am, very senior pediatrician from Rajasthan has joined. Achla, ma'am, are you there? I think she's not here. Dr. Asha Benkappa, ma'am. Asha, ma'am, would you like to comment something? I think she's left. Dr. Swati Khate, ma'am, again.
Can I say something? Hello? Hello?
Yes.
I'm Premlata Krishnan.
Yes, ma'am.
I just wanted to really, it was a very nice program. And I really wanted to emphasize that convincing the parents that something needs to be done is the first step. Many times they're in denial. When they come for a visit, which is not, when they haven't noticed a behavior issue and the pediatrician notices it, it's often quite a task to try and convince them. So we have to be very persistent about doing it.
Yes, ma'am.
Yes.
One more thing I would like to add, that we do so many programs of IAP programs in schools. During that time also, we can make the school and college administration aware about the screen time. And we should try to convince them that copy or homework should be written on the copy rather than providing on the online course.
Yes, sir. Each one of us should pursue it.
Yeah, definitely.
Anuradha ma'am, can I complete my sentence?
Yeah. I think anyone else? Anybody want to say something?
Alpana ma'am wants
Yes,
to.
yes, everyone. Thank you so much.
मेरा sentence
Madhu
अधूरा रह
ma'am,
गया था. Can I complete it?
Okay, Dr. Alpha.
Am I
yes,
audible?
Dr.
Yes, ma'am, you are audible, ma'am. Please go.
Yes,
तो
yes.
वो मैं जो बोल रही थी about
Anuradha?
the
No,
mobile
Alpana, yes.
homework वगैरह.
Yes.
Every OPD case I ask them homework कैसे आता है and I tell the parents you please go and report to the principal and एक group बना के आप लोग जाओ and you oppose it. Second query was ma'am the speech delay हम देखते हैं बच्चों में. Can there be some very short type of webinar or something to teach us pediatricians to just guide our patients in the OPD only कि हम उन्हें कैसे बता सकते हैं? Because it is very difficult for every parent to go to big cities. फिर उनको बोला जाता है कि you stay here for 10 days, you take the lessons and then you go and practice it with your child. तो अगर ये हम लोग को like we are in district places, अगर हमको ये थोड़े से short lessons आप ही लोगों के द्वारा मिल जाएं और हमको थोड़ा सा एक आइडिया मिल जाए कि हम कैसे उनको अपनी ओपीडी में थोड़ा टाइम देके सिखा सकते हैं, तो it would be easy if it is possible. You can see to it, please. Thank you.
We'll plan next sometime this type of webinar.
We do have some early intervention things, modules made, so we can, if WPF takes up this activity, it would be great.
Yes, Shikha, we'll keep in mind.
Yes, ma'am.
It's time for vote of thanks by Dr. Alpana Shukla, our Joint Secretary.
Yes. Thank you, Anuradha ma'am. So it was a really extremely nice session and a very informative one for all of us, for all members of WPF. So first of all, I would like to thank Dr. Shikha Garg, the moderator. You've done your work excellent well, ma'am. And Dr. Jaya Shivalkar, ma'am, Dr. Nirali Luhia, ma'am, Dr. Anshita Arora, ma'am. The experts, you all have given your extremely, very informative messages. Thank you very much for same. Dr. Madhu Raturi, ma'am, our chairperson. Dr. Asha ma'am, Dr. Preeti ma'am, Dr. Alok Gupta sir, and all the seniors who have spared their time to come with us for this WPF webinar. And of course, thank you, Anuradha ma'am, and thank you all the participants without whom it would not be a success. Thank you very much.
Thank
A
you so
message
much.
from our chairperson, Dr. Madhu Raturi ma'am, about our Jaipur conference upcoming. Madhu ma'am, are you there? Madhu ma'am?
She's not there. वो बाहर थी ना? She was somewhere else.
She's
आप ही
muted,
बोलिए.
I think.
आप बोल
So
दीजिए.
I
आप बोल दीजिए.
request everyone who has not
You are
registered.
muted, Madhu ma'am. You are on mute.
I'm at some other function where is a lot of noise. I'm standing outside. So thank you so much, everyone, for joining. That's it. Okay.
Yeah.
Okay, dears.
I would just like to thank my esteemed panelists for giving such beautiful inputs. Thank you, and thank you all the participants. Yes.
Please switch on your cameras for a group photo. Everyone. Please switch on your
Thank you so
camera.
much.
Please keep your cameras open. Yes. Everyone, please. Not many are switching on. Fine. Thank you, everyone. Thank you for the joining. We'll have our next webinar on Women's Day.
Thank you.
Thank you.
Thank you all.
Thank you, Dr.
Thank you.
Kalpana.
Nice, Dr. Radha. It was a very nice session. Thank you.